Assalamu alaikum and welcome to this lecture on Polyhydramnios. This is a shorter lecture and it will be followed by a second shorter lecture on Oligohydramnios. So we want to, in this lecture, understand what is polyhydramnios, the causes of it, appreciate its implications, and learn a little bit about the management of polyhydramnios. So let us start with this question. What is polyhydramnios? So I take a time and answer this question. Poly, of course, means a lot. Hydramnios means water, so amniotic fluid in this case. So it means there's a lot of amniotic fluid. Amniotic fluid has a purpose, which is to protection of the fetus and allow space for the fetus so the fetus can develop the lungs and the limbs into this space and grow into this space. Without fluid, the uterus, a strong muscle, the uterus has a very strong muscle, would clamp down on the fetus, and the fetus cannot develop properly into the space. So what is normal? If we talk about a lot of fluid, there has to be an amount of normal fluid. What is normal? Yeah, normal is around 800 to 1000 milliliters at 36 to 37 weeks gestation. You see, it's a small number of women who present with more fluid, so 0.15% is not a lot of cases. And of these cases, most of them are mild. So what are the causes of polyhydramnios? And you're right, there's not so many causes. So idiopathic is the most common cause, which is 50%. Then you find maternal, fetal, and placental causes. So please write down the maternal, fetal, and placental causes that you know. So maternal causes include diabetes, infection. So for example, parvovirus 19 infection. This causes aplastia in the baby and can therefore, it crosses the placenta. So if the mother is infected with parvovirus 19, it crosses the placenta. It can cause aplastic, aplasia in the baby. So a severe depression of the bone marrow and production of blood cells, and this can lead to, of course, severe anemia, and then following that fetal hydrops, and also polyhydramnios. CMV, toxoplasmosis, rubella, syphilis have all been implicated to cause polyhydramnios. It might be just an association with a large baby, fetal macrosomia. And finally, sometimes it is also due to autoimmunization, abnormal antibodies leading to fetal hydrops, and as a result to polyhydramnios. What are the fetal causes for polyhydramnios? These are important causes, and they are related to the fetal not being able to swallow amniotic fluid, so that amniotic fluid builds up over time. And this happens due to three reasons, but two common reasons, which are absence of swallowing makes a buildup of amniotic fluid. So these are neuromuscular diseases that the baby has, that the fetus has. The others are anatomical abnormalities of the GI tract, causing a blockage and an inability, therefore, for the fetus to swallow. There's also twin-to-twin transfusion syndrome, and we will talk about this at the end of this lecture a little bit, where you can sometimes find one baby having oligohydramnios and the second having polyhydramnios. And then sometimes fetal trisomies 21, 18, 13 might be associated with polyhydramnios, but they might equally be associated with oligohydramnios. So it's not that kind of consistent here. What are placenta? And I'm sorry. Alhamdulillah. What are placental causes? Placental causes are very rare, And they are mainly placental abruption, which is then an acute polyhydramnios, and this is not what we're talking about this time. And there might be also chorioangioma, which is very rare. It's a benign lesion of placental access capillary, formation of villus and absence of villus differentiation. So presentation of polyhydramnios can be mild or severe, and we distinguish this between mild and severe presentation. What do you mean? What is the difference? Just write it down with your pen on your paper, what you expect in mild and what you expect in severe polyhydramnios. So mild often has no symptoms, is often asymptomatic, and can appear just as large for dates. Severe polyhydramnios is different. Severe polyhydramnios causes discomfort and pain to the patient. It might cause problems with the breathing, the respiratory system, and there's a definitely this patient appears large for dates. There's there might be this might also cause premature labor or pre-labor rupture of the membranes as well. Even premature pre-labor rupture of the membranes if it's very severe. So how do you diagnose polyhydramnios? That's right. You need you can examine. Do an examination. So during the examination, you will find an increased symphysis fundal height. You will find it difficult to palpate fetal parts. And often this is suspected at a routine examination. Okay, so the mother goes to routine antenatal checkup. The symphysis fundal height is found to be increased. The palpation is the midwife palpates and finds that it's difficult to find fetal parts, and then she refers it and says suspected large for dates, and then further investigations are done to find out. So what are the further investigations? And that's of course the ultrasound scan. So polyhydramnios is diagnosed by measuring the amniotic fluid index. The amniotic fluid index is easy to measure. You have to put the probe on all, so you have to divide the mother's abdomen into 4 quadrants and then measure amniotic fluid pool in each one of these quadrants. You put the probe at the side of the mother, so not on the top of the abdomen, because there you will have many fetal parts and umbilical cord in the way. You put it at the side of each of the quadrants, and you measure a depth of a pool of amniotic fluid, in which there is no fetal part and no cord. You measure that in centimeters, and then you add all 4 measurements together, and this is the amniotic fluid index. The problem with this is, of course, that you want to measure a 3D measurement, a 3D volume, with the help of a 2D technique. Therefore, the amniotic fluid measurements are always just an estimate. They are not an exact measurement, because you do not take the fluid and put it in a graduated cylinder and say, this is exactly 853 milliliters. No, you can't do that. You have to kind of estimate this a little bit. Therefore, there's always a little bit of it's always slightly inexact. So but we know that an AFI of more than 24 centimeters is a lot, is polyhydramnios, is abnormal. Or a single largest pool of Leica over 8 centimeters, but it's not so common nowadays to use the single largest pool of Leica as a measurement. It's more common to use the AFI, and this is abnormal if it's more than 24 centimeters. So here you can see a picture, just so you know. This is kind of normal amniotic fluid, but this is a little bit more, so polyhydramnios. And this is a single pocket of fluid, and you can see that the measurement is 10.6 centimeters. So this is way more than 8 centimeters as it is supposed to be normal. And this is an AFI measurement, and you can see it's at the side of the baby. You can see there the face of the baby. Actually, you see the nasal bones, very nice, and the palate in this picture is a very nice picture of that. But at the if you go to the side, then a little bit, when there's a pocket with no fetal parts and no umbilical fluid, you can do the AFI measurement, and this is how you do it. So when you have diagnosed polyhydramnios and kind of estimated the amniotic fluid index, the important thing is to find a cause for this polyhydramnios. What actually causes it? And what do you have to do for that? I want you to take your piece of paper and write it down, stop the video and restart once you've written down the causes that you can remember. So you have to do laboratory tests for that. The most important test, and the test that's done immediately, is a random glucose, because diabetes is associated with this so frequently. It is very important to check that this woman does not have either underlying pre-existing diabetes which has not been recognized, or gestational diabetes which is kind of not controlled. Depending on the random glucose, you want to follow this up with a fasting glucose, and rarely also with a glucose tolerance test. In the past, we used to do a torch screen for every person presenting with polyhydramnios. We do not do that anymore, really, because it is not cost effective. So these infections have become rare and are a very rare cause of polyhydramnios. But if you have certain suspicions, if you maybe have other hints within the fetus, maybe you have microcephaly, maybe intracranial calcifications, or any other things that hint you to maybe there's an infection here, something else going on. If that is the case, you have to check the torch screen as well, or if the mother has any symptoms of an infection, of a recent infection, you have to check the torch screen. The torch screen includes toxoplasmosis, rubella, CMV, syphilis, and parvovirus 19 as causes for polyhydramnios. Very important, though, is a very detailed ultrasound scan. A detailed ultrasound scan with an anatomical survey that looks for any fetal abnormalities. Here is an a normal abdominal ultrasound scan. So you usually see one bubble for the stomach, and there should be always, you should see that, okay? So there should always be some water in that stomach, so some amniotic fluid that the baby has in the stomach, and this should always be visible. You can also see the spine there. You can see it. It's kind of on the left. You can see the spine, and then you can see the umbilical vein. Okay, this is what an abdominal circumference look like. If you look and want to measure the abdominal circumference, this is how you do it. You also see, so you see the spine in the ultrasound picture on the left, and you can also see both of the ribs coming from this spine. But then you might find this ultrasound picture, and this is what we call a double bubble. So here you can clearly see this is also the abdominal circumference, but you can clearly see not only one stomach bubble, but you see two bubbles. And these are due to, I know, I can hear you all say it, these are due to abdominal the duodenal atresia. So you have one bubble for the stomach. This is normal. But then you have a duodenal, some water going into the duodenum, and there you have a duodenal atresia, and a second bubble because the water cannot go anywhere else, and it collects in front of the duodenal atresia, giving a second bubble here. A very typical picture. You can also have a picture of a tracheoesophageal fistula, where you find a small stomach. Okay, where the stomach is especially small. So, what are the implications of polyhydramnios? So, what sort of problems can polyhydramnios cause to the mother or the baby? So, antenatally, it can cause discomfort, preterm labor, premature rupture of the membranes, or pre-labor rupture of the membranes. But intrapartum, it can also cause some problems. Okay, so the problems it can cause intrapartum are that you might have malpresentation because due to the increased fluid, the fetal head cannot engage into the pelvis. You might have a cord prolapse for the same reason. The head is not engaged properly and the cord prolapses in front of the head. Or you might have obstructed labor due to malpresentation, due to a big baby, due to a malposition, because when the head kind of went into the pelvis, it went in a funny way due to the increased fluid. And usually what happens is you have an extended neck. Head of the baby, so the head does not flex properly because of the excess fluid, but it extends and enters the pelvis into an extended mode. This can lead to problems such as brow presentation or face presentation. So the management is depending on if you deal with mild or severe polyhydramnios. Mostly, as I said at the beginning, mostly the polyhydramnios is mild, and this can only be observed. So you can observe and measure baby's growth, baby's development, as well as AFI regularly, and kind of see how this kind of develops. You have to, of course, if there's any diabetes, underlying diabetes, that has to be treated and controlled aggressively. The main stay of treatment are close observation antenatally with regular checks and possibly biochemical profiling. Any look out for preterm labor, okay, and also maybe give antenatal steroids to help fetal lung maturation because you're kind of scared that this might lead to a preterm labor, so it's better to give the antenatal steroids prior to that, so that the patient, should she deliver early, is prepared. This is especially help. This is not needed in mild polyhydramnios, but in significant to severe polyhydramnios. There's also a couple of antenatal interventions too. So first of all, there's amnioreduction, which basically means it follows the same principle as an amniocentesis. In an amniocentesis, you take about 20 mils for investigations from the amniotic fluid, but in amnioreduction, you take around 400 to 600 mils from around the baby away to discard the fluid. There's a few problems with this. First of all, you can induce PROM with it, you can induce miscarriage with this procedure, and it can, if you take too much all at once, it can also lead to abruption. But these are rare complications. But there's another problem with that. So if you do an amnioreduction, it is highly likely that after a week, 2 weeks, the amniotic fluid has accumulated again, and then you have to again repeat the amnioreduction. And every time you do an amnioreduction, you also increase the risk of infection and chorioamnionitis, because every time you kind of insert a needle, although it's of course sterile, there's always the risk that you introduce infection as well. Sometimes this can be used if prior to labor, if you plan to if this patient plans to deliver, you plan to induce the patient, so you reduce the amniotic fluid prior to induction so that you have less problems during delivery. Another way of treating polyhydramnios is with indomethacin. Indomethacin is a non-steroidal anti-inflammatory drug, which by using this, we actually, that non-steroidal anti-inflammatory drugs are actually not allowed to be taken in pregnancy. They should never be taken in pregnancy. They should never be taken because they can reduce renal blood flow to the baby and therefore have an impact on renal function of the baby. But exactly this is the side effect that you use when you use indomethacin in treating polyhydramnios. Here we use indomethacin because we want the renal blood flow to be reduced and renal perfusion to decrease, so that less urine is produced by the baby, and with less production of urine you have less amniotic fluid and you reduce polyhydramnios. So this is also a way of treating polyhydramnios. You see, it doesn't of course treat the underlying cause. This is not possible. Especially if there's an anomaly or anything like that causing it, but it can be used as such. Of course, it has to be stopped on time so that it doesn't come to persistent ductus arteriosus. So we have or premature closure of the ductus arteriosus. So you have to stop it at latest at 36 weeks. Some people say at 34 weeks actually. So this is a picture of an amnio reduction. In fact, this shows a twin. This is a picture of a twin-to-twin transfusion syndrome, where you have one big, large baby and one small baby in the corner. And here you do an amnio reduction of the amount of fluid with the baby, with the larger baby. This is also a picture, an ultrasound of an amniocentesis. So this is not polyhydramnios, but the picture is the principle is the same. When you do amnio reduction, you use an ultrasound, you insert a needle into the amniotic fluid under ultrasound guidance, and you remove fluid from the uterus like that. And here is amnio reduction in polyhydramnios. You can see here also there's a picture of an amnio reduction. You see at the top there's the reflection of a needle. And this is how it is done in. This is again a picture of an amniocentesis. There's no polyhydramnios. But this is how you do it. You have somebody holding the ultrasound probe, and then you clean the abdomen, and you place the needle where you avoid the placenta and where you have a good pool of amniotic fluid to kind of remove amniotic fluid from. So I just want to tell you briefly want to talk about the management of twin-to-twin transfusion syndrome. Twin-to-twin transfusion syndrome is actually caused by an anastomosis within the placenta between monochorionic twins. It does not occur in dichorionic twins. It only occurs in monochorionic twins, where you might have an anastomosis. Via that anastomosis, you have then one donor twin, which gives blood, which gives fluid blood to the recipient twin. And therefore, you end up with one small twin with oligohydramnios and one large twin with polyhydramnios. At this point, I always ask, which of the twins is at higher risk, the smaller or the larger twin? And you would be right if you had said the larger twin, because the larger twin gets a fluid overload, which is difficult to compensate for these babies, and they might end up with heart failure due to that fluid overload and high drops. Whereas the smaller twin also has a difficult time actually, but it can usually compensate a little bit better with a reduced fluid volume. Can kind of reperfuse, so take away fluid blood supply from muscles and put it to the important organs such as the heart and the kidney, and therefore survive a little bit better. There's one effective treatment for twin-to-twin transfusion syndrome, which is to identify the anastomosis between the placenta and laser coagulate it so that it stops. This is a very specialized procedure which only few centers do in every country. But it kind of is the way to kind of heal this problem of twin-to-twin transfusion syndrome, and it's the only a definite cure. So this is another picture of such. So this was a drawing where you have laser applied to the anastomosis between the twins, and here's another picture of how it is done on the ultrasound. So we already talked a little bit about the risks associated with antenatal intervention for polyhydramnios. There's the risk associated with amnioreduction, is mainly chorioamnionitis, and damage of placental vessels, hemorrhage, and also miscarriage could happen. So, or rather, at this point, it would be called not miscarriage. It would be rupture of membranes, and premature labor might be induced by antenatal amnioreduction. And the risk of indomethacin is the premature closure of the ductus arteriosus. Therefore, it should not be used after 35 weeks. It is important in polyhydramnios to plan delivery well. So either you do a cesarean section if the polyhydramnios is kind of significant, and you have a mild presentation, maybe even a transverse lie or unstable lie of this baby, or high head, you should always do a cesarean section. If the polyhydramnios is not that significant, and you can maybe manage a controlled ARM where somebody stabilizes the baby and somebody does an ARM but this has to be done on the labor ward when you're kind of ready to do a cesarean section. In case you have a cord prolapse, you can immediately do a cesarean section. Whatever you do for polyhydramnios, there's a higher incidence for cesarean section for complications. Now, at this point, I want to ask you, of course, if you have any questions. We can discuss them, I hope, in one online session that we can have. So write them down and we can come back to that. Thank you very much for listening.